the narwhal was just obvious.
Yeah. So it's 8:30, so we'll get started, I guess. We have 20 minutes to talk, and this was originally submitted as like a 50-minute talk, so hopefully we get through most of the things. But, you know, again, small group, so what's wrong?
Well, I was going to grab mics, but we
I think we're loud enough, right? Okay,
Yeah.
cool.
All right. I'll be the clicker.
Okay.
Yeah.
Yeah, so introduce yourselves. I'm Carrie Weisenthal. I'm from Boston Medical Center.
I'm Chris Burrish. I'm from the University of Washington.
I'm Natalie Sturks. I'm from UMass Bay State in Western Mass.
That's right. Disclosure.
Yeah, we have a couple of grant funding that you guys can look at on the slide deck. We're going to define harm reduction. We want to talk about different harm reduction strategies. We're going to quickly go over some common barriers and facilitators for doing this work. So what is harm reduction, right? So we do this in our work sort of on a daily basis. There's a couple of different definitions, but essentially it's a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on the belief in and respect for rights of people who use drugs. It's also evidence-based, and it was also started by people who use drugs at a time where this was all sort of criminalized activity.
Okay, so why harm reduction? There's a lot of good reasons why harm reduction, as you can see from this slide. This is actually from Bay State, where we had a grant to create some additional material, and this is one of the ones that came out that we hand out to patients or families or whatnot, anyone who really wants to know about the why. But one of the things is not just to keep people safe and healthy, which obviously is very important in our line of work, but also to improve communication. There's a lot of mistrust in this community, and especially in this population of medical personnel. Their experiences, their past experiences have really been harmful, right, to them, as well as sometimes our experiences as providers, sometimes it's not the greatest as well with patients who use drugs. So creating some sort of form of communication as well as trust with like just little steps, even especially harm reduction, can really help the patient population. We've had, I ran focus groups when I was doing this grant, and one of the things that we heard over and over is, oh, I lie to doctors. I tell them what they want to hear. I tell them I'm going to stop using this visit. You know, that way they can treat me better. And obviously, we don't want our patients to lie, so we want them to be open with us, and we want to meet them where they're at and where they're ready to be at.
And they lie because we've trained them to lie, right? Someone comes and says, I'm an opioid withdrawal, we're like, okay, bye. And if someone comes in and says, I have belly pain, we'll actually treat their opioid withdrawal and give them like morphine and Zofran and make them feel better. You know what I mean? Like, and this is not on them for lying to us. This is like how we have trained them to communicate with us.
Yeah. And I think, you know, a lot of people that use drugs or have addictions, you know, most of those people that have heard up to 75% are going to recover. And our job is just to keep them alive long enough to do that. And so I think harm reduction works in a lot of different ways.
And so many of you have probably heard me say this before, and many of you may have seen this slide before. That and this is 1 year mortality following a non-fatal overdose in the emergency department. It's 5.5%, right? So 1 in every 18 patients you see in the hallway who suffered an overdose but survived it will be dead in a year if we don't do something about that. 20% of those happen in the first month, with the largest spike in the first 24 hours after discharge. So this means we are discharging our patients. They are walking outside of our doors and they are dying, right? So sometimes I hear like Carrie, like, well, that's why we have like addiction clinics and harm reduction drop-in centers. And the point is that our patients don't have time to make it there because they will die before we do that, right? I don't think there's any other disease process that sort of has this immediacy in terms of mortality that we're just like, man, someone else's job. Right? So these are our patients, and this is part of our work. And harm reduction is a really important way that we can start engaging with our patients around sort of issues of ways to keep themselves safer in the setting of doing activity that is inherently unsafe, like riding a bike.
I do think that this statistic is really fascinating, right? Because people that have like a STEMI and go to the cath lab, their 1 year mortality is 7%. It's almost the same. And you think of all the training and all the resources we put, you know, there's a code STEMI, the cardiologist comes running, the cath lab comes in, they fire that baby up, you know, we're like, hey man, aspirin, all the stuff. And, you know, and if you don't give aspirin to somebody with an MI, like you're gonna have some meetings about that, right? But if you don't give naloxone to somebody that just had a non-fatal overdose, it's like, you know. So it is a striking difference in the way that we treat these two, I think, very similar, very morbid diseases.
And this is just to point out, this is evidence-based, so this is still part of the US Health and Human Services.
As of yesterday.
Strategy. Right? So I mean, this is like the WHO, the NIH, SAMHSA, like your local state public health department. Like everybody is on board with the idea of harm reduction, so I think it's time that emergency medicine does as well.
And so we should all be doing this, right? We should be handing out naloxone left, right, center. And it's not just for people who use opioids, right? It's, you know, a significant portion of people that are dying of overdose are people who are using methamphetamine or cocaine, but you just can't, I mean, where I work, fentanyl's in everything, right? Like something like 96% of everything that doesn't come from pharmacy has fentanyl in it. And so everybody who's using really anything deserves some naloxone. And some states have laws saying that you have to distribute naloxone, while other states do not. But I would say that the prescription fill rates for naloxone are generally quite low. If you're just going to write them a script like, here, go get yourself some naloxone, that's probably not going to happen. And so handing out.
And there's other ways of harm reduction besides naloxone, right? Like you don't have to have naloxone in your ED. It's optimal, obviously, and we would love everyone to have it. But there's also wound care, right? If you can't give out needles in your state due to laws, you can give them Band-Aids, you can give them alcohol wipes, you can give other things that will help prevent infections from causing, and you can also counsel them like, hey, don't lick your needle. Like that is a common practice, and they may have learned it from someone else and just carry it on, and they don't think about all the bacteria in their mouth before they go and inject their skin. So it's an easy thing to have that conversation and talk to them about, hey, this could save your life, this might not give you endocarditis or an SEA, so.
So at Boston Medical Center, we actually have a policy, a harm reduction policy that allows us in our state, our state is one of the states that allows us to hand out drug use supplies. And if you're thinking about doing this work, there's a couple of different strategies to go about it. We started just being like, okay, we'll just start doing this and everyone will be fine with it. And we found out that there were all these side conversations happening where people were like talking about reasons why they didn't want to do this and then sort of just putting up blocks, and none of those like reasons really evidence-based. So we decided, let's just write a policy and then we can talk about it in the committee and everybody has to say the thing, right? There's a pink elephant sticker, which is amazing. Like, you're gonna talk about it. If you don't get the person to say the thing, like, Carrie, aren't you just encouraging people to use drugs? Doesn't this tell people that we give them up on them, right? If they don't say that thing, you can't address it and you can't talk about the evidence based behind it. The fact that when New Haven started handing out needles, rates of circulating HIV dropped by like 2/3, right? I mean, there's like a large body of evidence that shows that this is important work to do, but if you don't have that conversation and people don't talk to you about it, you can't address it. So we actually pursued a policy that we got passed that allows us in our department to hand out safer use supplies. So needles, syringes, pipes, can't emphasize the importance of pipes enough, fentanyl test strips, and condoms and diaphragms.
Do you want to talk about the nursing aspect of it?
Yeah. So in this policy, the initial, so this policy 1.0, everyone in the department could hand out supplies. The pharmacists, the social workers, the doctors, but the one person who couldn't would be the nurses, because there was concern about nurses losing their licensure if someone got the supplies and then they later overdose and die. There was a group of nurses, however, that really wanted to do this work. And so they actually queried the nursing board of Massachusetts and said, hey, do you guys have a policy or a stance on is harm reduction part of the nursing scope of practice? And they actually put out a ruling where it said it is in fact part of the nursing scope of practice, including the provision of drug use supplies, and that no nurse should be held liable or have their license taken away if someone overdoses as a result of this. So if you're in a state where like your medical or nursing board hasn't put a comment on this and people are worried about that, ask them to. Write to them and say, hey, we want you to like put a comment on this. And by the way, here's all the evidence behind it. Like, give them that.
Yeah, it's pretty epic.
These are our supplies. There's an epic order. It's linked to take home naloxone. And the doctors 24 hours a day can go in the ortho closet, or the room of requirement where I call it, where all the cool stuff is, like the eye care and stuff, and just pull out the supplies and hand them to patients on discharge.
I think we can go past that. So we've been handing out naloxone in our emergency department, but really tried to pivot to doing more harm reduction supplies. We made these kind of safe injection kits, safe smoking kits that were put together by people with lived experience, or sort of designed by people with lived experience. And we were pretty stoked to start handing them out. We had an institution-wide policy that we could do this as a pilot. But because it was a pilot, they only wanted the attending physicians handing it out. Nobody else could hand it out, and it had to be just as the patient was walking out of the hospital, not while they were still there. Like, it had to literally be striding out the door before we could. I mean, it was tricky. There were a lot of limits around it. And so we kind of wrote a policy, and we were really excited about it, but the side conversations got louder and louder and louder, and nobody really wanted to say the thing because they were afraid they would sort of lose their sort of like, I'm cool credential card, right? And so, so we put together a survey monkey, like an anonymous survey monkey, and I can never get people to respond to these things, but this thing broke survey monkey. It just like, I think within 24 hours, maybe 48 hours, it was full and it couldn't handle anymore. And the big objections that we heard from folks were, hey, as an attending physician, I'm already totally overburdened. Like, I'm already kind of maxed out. It's just like one more thing I have to do. We don't feel like the data that you presented us is good, particularly for the safe smoking supplies. We don't feel like there's enough data to really feel like this is sort of evidence-based or is going to make a difference. You know, we think that it does feel like we're sort of enabling harmful use. You know, like we're saying don't use, but then we give them the stuff, and it's sort of a mixed message. And this isn't really our wheelhouse. Like, we have syringe service programs, right? Like, we have places people can go for this. And it is true. I mean, we're handing out, like, I think our kids have like 4 syringes in them, but they go to like the needle exchange and they get a box of 300. And so, so that is kind of true. But then the other big concern is like, what is the media going to say, right? We just passed a bond to build a new emergency department. The whole county's chipping in to pay for it. And like, you know, they're going to show up with news cameras and be like, that's $70 million you all voted for. That's just going for drug supplies. And you know, I mean, I think there's some legitimate concerns there, but it takes, yeah, this is one of those things that I'm hoping that changing the practice is going to change the culture a little bit.
Yeah, so I work at Bay State. We're in Western Mass. We're like the only level 1 in the area. And thankfully, when I started residency, we already had harm reduction. Dr. Bill Soares, who's in the room, had already come to our institution and slowly kind of wiggled in the harm reduction. First with like supplies to clean the skin, eventually the needles, and then, you know, it was present, but not always like in your face. You had to go into the med room, you had to find it in the cabinet. He was doing all of the bagging of things and supplies on his own, as well as doing research and working. So, you know, the harm reduction program was there and everyone had sort of accepted it, so it was great. I became a health equity fellow a couple years ago, and when I did, we got a grant, and we got a grant through RISE because I started seeing people who were overdosing that weren't actually trying to use opioids. They were, you know, cocaine or whatnot. And so, of course, we created the spirit animal, part of the campaign, and our narwhal is our spirit animal for naloxone, which, of course, you can get a sticker if you haven't already. And that sort of like prompted a whole different like addition to our harm reduction. We started giving out smoking supplies, sniffing supplies, and then we created this lovely cart that is a lot more visible. We put wallpaper on it, so it doesn't look like every other cart in the ED. And then we also put a lot of information so that anyone could access this cart, and we had like a harm reduction day, and we gave out cupcakes or cake and balloons, and you know, we had people come and look at the cart. And so all of this is also with our community partners, right? So our smoke and sniff kits are created at one of our community sites who gave us a lot of information on what they wanted to see with, you know, handouts as well as resources, as well as what's in the cart. Like we even have granola bars, soft granola bars, so that, you know, you get a little treat. If your teeth aren't great, you don't have to worry about like something hard.
And I think it's an important part to emphasize, if you're going to do this work, partner with your local harm reduction service. Drug use is like very local. Patterns are different. Some people will inject differently in different cities or states, or different drugs are preferred. And like they will be so thrilled. Like if you go to like your local harm reduction site and like, hey, I'm an ER doctor and I want to bring harm reduction to ER, they're gonna be like, yes, how can we help you? So like ours, they applied for a grant to fund the supplies. They keep our like closet stocked with supplies. And so like they are invaluable partners, and if you will do the work better for having, and pay them for their time. Also, I think that's the other thing to think about. Like actually do pay them for their time.
Yep, we pay them for the kits They actually subsequently got another grant working with us, so through the same foundation, through RISE. So they're very like, they're doing that grant right now and they're so on board. And they're always like a constant call or text away.
I think it's also interesting when you're engaging with local harm reduction places to sort of secret shop for it. Like I kind of hung up with Prof for a while and didn't tell them that I was neurodoctor. It was really, really interesting and humbling and embarrassing to hear all of the feedback that people had about the emergency program. I mean, like, yeah. So I think I think that just really kind of embracing that perspective, both formally and informally, and understanding the way that there's a lot of historical trauma, as we mentioned earlier. So, but yeah, I think obviously if you're going to engage with folks, it's super important to do, and they need to feel valued and respected for their time. I think that's it.
Yeah, after doing this, just have compassion, I would just say, for your colleagues. I think one of the great privileges of doing this work is that I get people coming up to me all the time telling me about their brother that died of an overdose, or et cetera. And sometimes it's some of like the meanest people. And the way that I sort of rectify that is that I think about like if I was doing tough love, which is what everyone's told they're supposed to do, and then some smarmy doctor come in and say, hey, let's do harm reduction, but your brother had died of an overdose last week while you were not letting them look into it. That's like really hard, right? And so I'd say I have really a lot of compassion for your colleagues as you're doing this, and a lot of like respect for understanding just like how wide the opioid epidemic is and how it really does affect your own community in ways that you probably don't know.
I mean, I feel like as we've started doing some of this stuff, and we're not doing it as well, my colleagues that have interacted with people and been like, oh man, this is really actually super great. Like, I gave them the stuff and now they're talking to me.
Yeah.
Or we had this conversation and feel like we're really connected, and we even had some patients write in and say, I thought I was going to be dead by now, and I'm not because of what happened in the emergency department. And I think that sort of acknowledging this trauma kind of on both sides, right? Like I think the EMS folks that are constantly responding to these calls, and EM folks that are seeing this day after day, like everybody gets hurt, and this is a way of I think helping everybody out, right? And I think mitigating some burnout. So I think it's everybody wins in this situation.
Yeah. I will say too, one of the things is never assume that you're going to be the one who is the expert on harm reduction, right? Or drug use. Ask questions, right? Especially if the patient says something and you're like, what does that mean? Like, be inquisitive, and usually they don't mind. They'd rather talk about it and explain it to you most of the time. But it's important to ask those questions and not necessarily say, oh, I know what's best for you. Like, that's the really important part. So if anyone has questions too, by the way.
We're out of time, but we're happy to take questions. If you want to learn more about this, invite us to come talk at your institution. We would be totally thrilled to come and give a talk to you guys about this in a longer format.
Also, these shirts are from University of Washington to help support their harm reduction program that they're trying to take. So.
Yes.
Sorry.
No, you can ask questions.
I apologize in advance if this is my colleague's scope. This is amazing. And as someone who is a neighbor to two of you and fights this fight daily, it's super cool to see how you kind of got around it. I'm interested to know, so like, back when I was in grad school, there was like, that was sort of when like the needle exchanges were really becoming popular, and the sort of Hopkins to West Coast phenomenon of like black tar versus white tar heroin sort of came to light, that like the needle exchange was just because of the nature of heroin differently effective on the West Coast than the East Coast. And so I'm curious now, many years later, if you're still seeing that trend, if there are things that are like regional that are more effective in some of the places just because of the nature of the drug.
Yeah. There's a great map. We don't have it here obviously, but there's a great map of like different drug use across the U.S. I think it's done by the CDC, I want to say, and so you can see like was done by the CDC. Sorry, I don't know if it still is being done by the CDC, but you can see like the differences in like methamphetamine use, like heroin, fentanyl, because essentially most heroin is fentanyl for the most part now. And then also like cocaine and other drugs.
Yeah, it's rapidly evolving, right? So in Philly, like you might have heard of, like xylazine was the big thing. Xylazine is almost come, is like exiting the market. It's all like medetomidine now. That's a big alternative drug supply. And so it's constantly changing. I mean, there was no heroin for like years, and then in Boston we saw like a little bit of heroin, and now it's like all fentanyl again, and we're getting some weird stuff coming in, like Tnuvin, like something they put in like plastic products to make it like UV like light stable to show nothing to. So and meth is now come all the way across the seaboard and is all the way on the East Coast now. We have a lot more meth in the last 5 years. So.
I mean, I think the nice thing about this is it's like an all hazards approach though, right? It doesn't really matter what people are using. You can get them to engage in care, right? Like, I mean, I would honestly probably give a kidney to have like a buprenorphine for methamphetamine. But we don't have like a great pharmaceutical option for that. But harm reduction still works, right? Getting people to engage in care and motivational interviewing and
giving them a pipe so they don't use a light bulb like to smoke their meth. Like that's like huge, right?
Yeah.
Like it's like toxic.
Yeah, I actually think that has been a big thing because I think a lot of the time we had stuff for people who specifically injected opioids, which meant that so many people felt outside of that, that it was easy to be like, oh, that's actually, we don't actually have anything for them. But now I feel like everybody's polysubstance. And so it's like, well, if everyone's polysubstance, you don't need to get down to the details of it.
Right.
Just go offer them, we have this menu.
Yeah,
Just
the
go
harm
offer them the
reduction
menu,
menu.
see what they want.
I mean, people will inject if they don't have access to a pipe, right? And anytime you can prevent an injection in that, like I'm preventing like HIV, endocarditis, etc. And then just there's like a health equity lens to view this with. The Harm Reduction Center, the biggest one near us, when they started offering pipes, they had a lot more Black women come in. And they were not just getting pipes, but they were also getting like injection supplies, right? So this was an entire population. They weren't reaching and didn't feel like they were welcome in their center until they started saying, like, I see you, I have the thing that I'm here for.
And there's data that supports that too, that they tend to smoke more, and so we were just ignoring their needs for a long time.
we're definitely out of time now.
Yeah. We'll hang out outside if anyone has any other questions and stuff.
All right, thank you.
Yeah.